Hi, everyone. This is the Society of Thoracic Surgeons user group webinar for Intermacs and PDMacs. Thank you so much for everybody for taking the time to join today. Today we have Dr. Kiernan from Tufts Medical Center joining us. Dr. Kiernan is the medical director of the VAD program and assistant professor at Tufts University School of Medicine. And he's going to give us a presentation today on temporary support. Real quick, before Dr. Kiernan gets started, I just wanted to review our agenda. As far as STS updates, we are going to be changing the way we handle RVADs when they are connected to an oxygenator and adding some questions to the forms. I'll be going over those changes a little bit later in the webinar. We also have Dr. Brandon Singletary joining us. He is going to go over some updates for us as well. He'll go through his once Dr. Kiernan completes his presentation, and we have some Q&A. Also, I'm going to discuss AQO 2023, which is going to be coming up at the end of September. And then depending on timing, we can have some Q&A. So that's going to be the agenda for our meeting today. I'm now going to turn it over to Dr. Kiernan, and I will stop sharing so you can share your screen.
All right, are my slides showing?
Yes.
All right, well, thanks so much. Welcome, everybody. I appreciate the invitation to talk today about early acute right heart failure or severe early right heart failure, focusing on RVAD use in LVAD recipients. So the objectives over the next 30 minutes are to be able to define the incidence of early acute right heart failure, as well as some other forms of heart failure, to be able to differentiate the types of right ventricular assist devices, and to describe outcomes following RVAD implantation across different RVAD platforms. In the way of some background, so we know that overall, the main Achilles heel of expanding durable LVAD use to a broader patient population has always been the risk profile of serious complications or adverse events. So historically, we know that approximately 70% of patients have a serious adverse event or major adverse event within 12 months of support. That means a minority, only 30% of patients are free of adverse events. However, with improvements in patient management and more likely driven by improvements in technology, namely outcomes that we're seeing with the HeartMate 3 device, we've seen significant and dramatic reductions in many complications. With VAD thrombosis is almost non-existent, where it used to be 10 to 20% of patients over time with the HeartMate 2. So these are Intermacs data. We're going to be focusing predominantly on Intermacs data, obviously, as this is the users meeting and how it's informed clinical practice and decision-making through the years. But what these data show are outcomes or adverse events associated with the different pump platforms. So the top line here is centrifugal flow full maglev. So that's the HeartMate 3. Below that, we have CF, HL, which is the HVAD device. And then below that axial flow is the HeartMate 2. And what I want you to focus on is, so this is freedom from adverse events. So higher is better. We can see that these lines separate for GI bleeding, stroke, as well as infection. So we see with the HM3 that there's improved what we label as hemocompatibility. So we're seeing reduction in bleeding and thrombotic events, but importantly, where we've made no progress and what remains an Achilles heel of durable LVAD use is persistent right heart failure. Now, this is not RVADs. We'll look at rates of RVAD specifically, but you can see that the magenta here for the HeartMate 3 is not better than the earlier iterations or earlier generation devices. We see this in a different format. This is early right heart failure, typically defined as either RVAD use or prolonged inotrope support greater than 14 days across a spectrum of clinical trials over the last decade and a half or so. And so where are we today? Well, data from the Momentum 3 trial, this is the HeartMate 3, we can see that we've not made any improvement. If anything, rates of right heart failure may even be slightly higher than with some other pump platforms. And we see right heart failure, the incidence here of being just over 30%, which was a little bit higher than with the HeartMate 2. And this likely this translates to a number of things, including people who develop right heart failure, we know have impaired functional capacity, impairments of quality of life, and are at risk of other complications as well. And what we know, this is not from Intermacs, these are data from the Momentum trial, and this is looking at the proportion of patients at these different time points who are class 1 or 2, so either asymptomatic or mild heart failure symptoms. And we know going into LVAD, the vast majority of patients are class 4, meaning they're essentially have fatigue at rest or with really any activity. And what we find is that over time, about 80% of patients now have mild symptoms following LVAD implantation, but that means 1 in 5, about 20% of patients have persistent, moderate, or severe heart failure symptoms despite having an LVAD. And we think that the majority of that population with persistent heart failure symptoms is likely being driven by right heart failure. Other things can factor into functional capacity. It is subjective, but things such as obesity as well as COPD or other reasons people could have disability or impaired functional capacity. But likely most of this is driven by, since the LV is supported, a myopathic right ventricle. So clinical right heart failure symptoms. So the vexing problem of right heart failure, and now transitioning to the focus of today's talk, which is really looking at RVAD utilization after LVAD implant. We know, given that we know over a plethora of studies that survival for BiVAD recipients is lower than those who receive an isolated LVAD, there's generally a preference in the community across clinicians to avoid an RVAD unless it's clearly necessary. But the question is, when is it clearly necessary? And that's a really challenging question to answer sometimes, and it's an inexact science, and we'll look at some profiles of that and from work from Intermacs. The ability to identify right heart failure prior to going to the operating room or even intraoperatively, that is a right heart failure that's severe enough to warrant an RVAD, again, is imprecise. It can be very muddy waters at times. Sometimes it's easy when patients are somewhat crashing and burning, but usually it's murky sometimes. Who can get by with inotropic support that we can wean over days or a week or two versus who needs to be transitioned to an RVAD. Many patients with marginal RV function are deemed only in the days or weeks after initial LVAD to warrant this second procedure, what we call a sequential RVAD. And so one of the big questions as we walk through these data is there risk with delaying it? And do we need to move more quickly to fully supporting our patients with an RVAD? What are the outcomes associated with the sequential procedures if patients don't get supported early and more aggressively with mechanical right-sided support? And then decision-making is further complicated by the choice of what type of RVAD to use. And over the course of today, we're talking about 2 different comparisons. So one is durable. So that would be, and we'll look at examples of that, but essentially using an off-label RVAD, such as the HeartMate 3 or previously the HeartWare device, and putting one in the right ventricle or the right atrium. And decision versus a temporary device, such as an Impella or a Centramag, and that decision often depends on the expected duration of support. So if we think someone has an isolated insult or hit to the RV and they'll recover, we would lean towards putting in a temporary device. If we think there's going to be irreversible damage, or we were so concerned going in and when we knew that we get strong and we thought the ventricle wouldn't recover, then it may make sense to go to a more durable option. And then lastly, we don't have, as you know, any commercially available FDA-approved durable LVADs. We'll talk just briefly about the total artificial heart, but we don't have long-term support that has been designed by device manufacturers for specific for the right ventricle. So that's a real limitation to the clinical management of these patients. So the first thing is prediction is, in fact, really difficult, as I mentioned, to determine who's going to have early severe acute right heart failure that needs an RVAD. And there's been a lot of science behind this. And part of the complexity is when we try to model the risk of these events, we can't incorporate. It's really hard to predict what the interaction between the right ventricle and the LVAD is going to be, and how the LVAD is going to impact contractile patterns of the right ventricle, how the RV will handle the increase in preload as the LVAD is now increasing left-sided cardiac output, things of that nature. Furthermore, it's hard to predict intraoperative complications, things like acute lung injury, bleeding, and vasoplegia. All of that can lead to uncoupling or decompensation of an RV that appeared stable going into the OR, but we can't account for that oftentimes in the preoperative period. So prediction is difficult. Lots of different investigators have done different analyses to try to determine risk scores, but generally speaking, these risk scores have performed pretty poorly when used in validation cohorts. This is what's called a receiver operating characteristic. For those who aren't familiar, essentially when a curve is close to 1 as possible, that would be perfect prediction, meaning if we had a positive score for an RVAD, then we knew that each of those patients really required an RVAD. And this is the line of no difference. If we're relying on this line, then it's a coin toss. The test is useful. So in general, in terms of discrimination, we consider ROCs greater than 0.7 to 0.8 to be considered somewhat acceptable, and then greater than 0.8 to be good. And you can see that the curve for all of these different models is in fact less than 0.7. So it is hard to identify these patients, oftentimes more so than just the eyeball test from the foot of the bed. Does the patient look like they've suffered from the sequelae of chronic right heart failure in terms of ascites and other stigmatic cardiac cachexia and overall frailty, et cetera. So going back in time a little bit, a number of years ago, we did an analysis looking just at this question, trying to describe patients who had early severe acute right heart failure defined as RVADs. There's other forms of right heart failure. The waters get even muddier, and we thought it was easiest just to identify RVAD versus not, because usually it's pretty clear in the registry who has an RVAD. What sometimes was a little bit murkier at that time was the exact timing of the RVAD implant as it relates to delayed or sequential versus concomitant at the time of the initial procedure. If that procedure occurred, for example, within the first 24 hours after the initial LVAD. But nonetheless, among these 10,000 primary continuous flow LVAD recipients, about 5% required an RVAD. And we were looking at RVAD use within 14 days. So the majority of RVADs that went in within a 2-week period. We found that RVAD survival, and this is similar to, again, a number of other scientific studies that have been performed, but in general, survival with an RVAD and an LVAD recipient is about 50% between 6 to 12 months. And that's what we found here, and that this is the hazard ratio that made patients who required an RVAD were 2.7 times more likely to die within the period of study than those who did not require an RVAD. And then lastly, I'm not going to go through all this in detail, but we weren't interested, given the limitations I just discussed about risk scores, in creating a new risk score, but we did want to create profiles of risk and who's low risk, less than 1%. What it is on average, what do patients with a less than 1% risk of requiring an RVAD look like compared to those who are moderate to high risk? And biochemical profiles in terms of what is their baseline kidney function and hepatic function look like. And importantly, we put a lot of stock into the hemodynamics. Intermacs, it collects data, as you know, on echo, but some of that data isn't as granular as we'd like as clinicians to help inform decision-making from the registry as it relates to echocardiographic parameters. But there are the hemodynamic metrics that are captured in terms of different thresholds of right atrial pressure, pulmonary artery pulsatility, as well as less dilated left ventricles. So we can start to get a sense what patients look like who are going to fall on higher risk phenotypes. And this was our ROC curve from that analysis. Again, it would perform moderately. This is not a validation cohort, so it would probably do worse. But what I want to highlight is the discussion between sensitivity and specificity. So if we have a test, if something's very sensitive, it means that we will identify all patients who require an RVAD, but we're going to guess wrong in terms of it not being specific, meaning some of the patients we identify, in fact, would do just fine probably with inotropes. So if you're overly sensitive, yeah, you're gonna pick everybody that requires an RVAD, but you're gonna overshoot and give many patients devices who probably don't need them. And the flip side of that, if you have something that's less sensitive, it means you may miss a lot of patients who actually require an RVAD, but everyone you choose to get one was a person who really actually needed it. So everyone who got an RVAD really needed it, but there's going to be a big population of patients who probably would have done better with it that you didn't detect with your test. And so overall, so that's what that translates to positive and negative predictive value. So these tests are good at when the test is negative, meaning is your RVAD risk score negative, we're good at excluding. We do okay with picking right in terms of patients who do okay with univentricular support, but it's really hard in terms of positive predictive value. And at best, it's 25%, meaning if they fall into a high risk category preoperatively, in fact, only 1 in 4 of those patients actually probably needs an RVAD. So again, the positive predictive value of these risk scores remains pretty low. And that's one of the key challenges in terms of identifying who we need to support with RVADs. So moving on to the data regarding from Intermacs, again, separate analysis. This has been published in the annual reports in the Journal of Heart, Lung, and Transplant, and now STS. And this is a comparison, again, of LVAD versus BiVAD in patients who received the HVAD device versus the HeartMate 2. Again, just demonstrating survival, as I showed previously, of about 50% between 6 and 12 months. So patients with BiVADs are clearly a different cohort. This isn't per se related to the platform, meaning it's not a device-related complication as much as it is that patients who require BiVADs are just generally much sicker and have worse outcomes. It may be a limitation, again, of not having adequate tools that are designed specifically for RVAD support. And again, the inertia or reluctance to use BiVADs in some of these patients. And sometimes we, try to skate by with just using medical therapy and inotropes. What are the different, as we look at current utilization rates for RVAD? So these are the different technology platforms that we're talking about. So there's the Impella RP, which is the device that's inserted through the femoral vein, comes into the right atrium, and then out through the right ventricle into the main pulmonary artery. So we're pulling blood from the right atrium and then pushing it. So we're directly bypassing the right ventricle and pushing it out into the pulmonary artery. There's different ways we can do that. So we can do that externally as well in terms of where the pump itself is sitting. So this is this can be a tandem or Centramag configuration, and it can be surgically placed, meaning open placement versus through the femoral vein and internal jugular vein. But essentially, we're again sucking blood from the right atrium out to an external pump like a tandem heart or a Centramag, and then pushing blood back into the main pulmonary artery. So we're directly bypassing the right ventricle. The Protect Duo is a single lumen catheter that comes in through the internal jugular, and it has 2 lumens. So one sucks blood out to an external pump, and then a more distal pores allow, again, blood to be exit distally into the main pulmonary artery. By the way, there is some centers on the call may have access, but there's been early release of what's called the Impella RP Flex, which rather than femoral cannulation is now going to be IJ cannulation. So it's the same amount of support, but now allowing greater mobilization, given that it's not femoral access coming from the IJ. So the Impella RP is an early release in some centers. And then there's direct cardiopulmonary bypass with VA ECMO, where we're pulling blood from, again, the right atrium coming out to a pump and now pushing it back into the arterial circulation. So we're actually, it's RV and LV bypass, not just RV, but these are the different means of temporarily supporting the heart in someone with severe right heart failure once the LVAD. And this picture down here shows that. So here's a patient in this cartoon with the HeartMate 2 who had severe early right heart failure and now has a Centramag RVAD that can be used for an extended period of time, but eventually weaned over days to weeks or sometimes months even. And then what about durable mechanical circulatory support? So this is a multi-center registry data from 6 European centers, small numbers of patients, 14. We again see similar outcomes, about 50% mortality between right around 6 months, between 6 and 12 months, but using off-label HeartMate 3. So HeartMate 3 BiVAD it can be used, again, not used very commonly, but it is an option. And there was some prior experience of doing this with the HVAD. Cannulation techniques vary, but oftentimes inserted into the right atrium. Different things can be done to the tricuspid valve, because what we worry about in this setting is there's a fairly high risk of RVAD thrombosis and ingestion from clot, which is more common in the venous circulation than in the arterial circulation. And we'll look at outcomes in the most contemporary analysis. And then lastly, other durable support. So here is some people may be familiar or not, younger people in the call, with the Thortec PVADs, extracorporeal pneumatic pumps. So when I first started, we still utilize these devices, over a decade ago to support our patients with severe biventricular dysfunction, but not clinically available. And then there's this, what is still available is the SynCardia total artificial heart. It can be a good option in this situation for severe biventricular dysfunction, but has been utilized at just a handful of select hospitals that have a lot of experience. And when you look at total volume, so this is data from the most recent quarterly report, just in comparison, over a year and a half period, there was only 15 TAHs implanted compared to 3,700 LVAD. So it really is a select few hospitals that have utilized. So it's only a couple of devices per quarter as it relates to TAH utilization. So we're not going to be focusing on outcomes with this device, but again, it's been similar. It's about sometimes better in expert centers, but I would say 60% survival at 6 to 12 months on average. Okay, so Moose Ahmed, who runs the program down at the University of Florida, has brought us up to speed with the kind of the most contemporary analysis of RVAD use in Intermacs. So that's what we'll spend the remainder of our time looking at where we stand today. Just to repeat what the definitions are, sequential means a separate surgical encounter. So a patient went to the OR, received an isolated LVAD, and then at some second procedure, they came out of the OR and went back. That would be sequential, as I'm sure you know, and concurrent. It occurred during the same surgical encounter. The analysis that I helped lead previously was a little bit different era. It was 2006 to 2015. So now we're looking at a decade, 2010. So there's some overlap, about 5 years of overlap, but we're looking now at 2010 to 2020. And just over 29,000 devices, but similar proportions. So overall, I had 5.2 in our analysis, and now it's 5.6. So essentially equivalent RVAD use. Just over 2/3 of those are concurrent BiVADs, and 1/3 are sequential. So they left the operating room and went back. And then the vast majority of devices in either arm, whether they returned or received it at the index operation, were temporary devices with a smaller proportion, so 8.5 and 7. So just around 8% of patients receiving a durable. And that means, a HeartMate 3 or an HVAD. It could have been an HVAD in this cohort as well, in both the right and left-sided position. What this analysis doesn't include when we start to focus on outcomes, it has LVAD only, but it doesn't per se focus on patients who develop severe right heart failure who go untreated with an RVAD, but probably needed one. And so when we look just here at the causes of death over time, so green here is right heart failure. So you can see that early severe right heart failure, in fact, is one of the leading causes of death. We see early stroke, bleeding, not surprisingly, in right heart failure. But what's difficult to account for, so while we do often capture death due to the right heart failure, this magenta, which is the highest, is multi-system organ failure. And I would venture to bet that the majority of patients who die of MSOF, it's really driven by right heart failure. And that can be difficult to define and capture. So it's listed as multi-system organ failure. but I would argue that probably the majority of early deaths and even bleeding-related complications are often related to early right heart failure, although it can be chicken or the egg. Bleeding and transfusion can also precipitate right ventricular decompensation. So looking at trends over time in Intermacs, we can see, so overall, these bar graphs represent patients who get an RVAD per year, and we can see that there is an increase RVAD utilization. The majority, so there is a change from up here where we see the 2/3, 1/3. The blue is temporary versus red is durable support. We can see that the greatest growth is in patients who receive temporary RVADs, and it's the vast majority of devices being utilized at this time are temporary. Just a handful a year are receiving that. Here it would all be HeartMate 3 BiVADs. There's only 10 that were recorded in 2022 and 16 in 2021. So the majority of these are either Centramag RVADs or Impella RP type configurations. So how do these patients do? Again, it really mirrors, and there's some overlap. Again, about 5 years of data worth of overlap, but in this contemporary cohort, again, we're seeing survival between 50 and 60% at 6 months and closer to 50% at 9 months. The vast majority of that risk is within that early period, really within that first month or so after implant, and then the hazard is fairly stable over time afterwards, meaning these two lines are parallel. The divergence really occurs in that early period, and patients who required an RVAD, again, are about 4 times more likely to die within 12 months compared to patients who receive an isolated LVAD. What is missing to some extent is being able to compare survival over error. So it would be interesting in the future is to say, how do patients really kind of just in the HeartMate 3 era, the last 5 years of 2018 to 2023 compared to the 5 years prior, because a decade is a pretty big window of time for a comparison here. And so it would be to truly look at contemporary outcomes, it would be nice moving forward to kind of isolate that to how are our patients doing with temporary support with the HeartMate 3, and does that differ compared to earlier era? My guess, frankly, would be it does not differ, given everything that I've told you, but it would be a point of interest to look at that. So now getting into the weeds a little bit. So looking at these different groups for comparison, they looked at survival. So this is among all patients who had concurrent. So those who left the operating room at the index procedure with an RVAD in place. So those are labeled as BiVADs. And looking at, does it matter if you receive an Impella RP versus a HeartMate 3 in the RV position, so temporary versus durable? And the answer is based on device type. When placed simultaneously, a concurrent operation, there was no difference statistically in survival. It does look like there's a little bit of separation early, with survival of 68% compared to 79%. These curves cross over time. That survival actually favors the durable RVADs, but it does not adjust for baseline characteristics. So it is highly likely and most probable that these patients that receive a HeartMate 3 BiVAD are likely dissimilar, not the same as patients who receive temporary support. Whatever drove a clinician to make the decision to put in a HeartMate 3 BiVAD versus a temporary RVAD, they may be very different patients. So no statistical modeling was done to account for those differences. But regardless, it looks like outcomes are pretty comparable, regardless of whether it's a temporary versus durable device. So that may just be driven by operator experience and kind of institutional experience. Understanding again that most the numbers for durable overall are pretty small. So hard to say that there's anything meaningful, even that early separation of those curves. Moving on to what about sequential? So still focusing on device type, temporary versus durable. Does it matter among just those patients who went back to the operating room? So if they left the operating room and returned for support once it was identified that they weren't doing well. And similar to the last analysis, there was no difference in survival. You can see that these curves overlap really from the get-go, and that overlap persists over time. So there's no survival benefit based on device type among patients who returned for a sequential device. What is missing, though, and sometimes it's hard to define in the registry, at least in my earlier experience with it, is that time. So this is sequential. Is you could have went for this, the purposes of this study, you could have went back within a month. So I think it was 29 days, or it could have been hours later, or it would have been treated the same. So, is it okay for a patient to leave the operating room, go to the intensive care unit, and with really close monitoring, give them 6 to 12 hours to make the decision about whether or not they're going to settle out and improve, or do they need an immediate RVAD? And I don't know that this answers that because it's unable we don't know how long the delay was. But certainly, as we're going to see, we're going to see shortly, it does appear from Intermacs that delaying increases risk of adverse outcomes. But one question is, again, does it matter on how long that delayed is? And the data before this analysis have been a little bit mixed, where some data suggest that delays aren't all that important, again, if it's with very close observation, where other analysis from the Penn group suggested that any delay really kind of increased risk of dying. So now we're looking at that question about outcomes if we delay. I'm calling it delayed. In the manuscript, it's called sequential versus concurrent or simultaneous placement. So this is now the next two slides just look at durable versus temporary, but they mirror each other. In red is concurrent. So the simultaneous RVAD placement patients do better than those when there's any delay in placement. And again, the risk of dying is about 2.5-fold higher when there was a delay to putting in that durable RVAD. Again, low numbers, so this would be the HeartMate 3 BiVAD type group. More importantly is what's going on, and I say more importantly just because it accounts for a much greater proportion of observations or patients, but when we're using things like a Centramag RVAD or the Impella or Tandem Heart Protect Duo, we see likewise that the blue line, the sequential or delayed placement leads to increased risk of dying. And that again is within that first month, that early period where these curves separate, and the risk here is 50% risk, or 50% more likely in terms of the hazard for dying if we delay placement. So suggesting observational data, again, not randomized, that you'll never see a trial where we know patients need an RVAD and we say, well, can we wait or should we go now? That trial is never going to happen. So right now, as we have, the strongest data we have is from this analysis suggesting that we should not wait, in that if someone's not doing well, we should try to make the decision intraoperatively whenever possible, understanding of the caveat that it's not always an easy decision to make. So what about outcomes? So durable is durable. Those devices are put in and they stay in until someone dies or gets a transplant. But in temporary RVAD recipients, there's different options. So a patient can die, and that occurred in 30% of patients. They can be bridged to transplant in that setting, and 21% essentially of patients went on to get transplanted. Or they can have recovery, or quote unquote recovery, where the RVAD is explanted because patients may be doing better. But among that cohort, which accounts for just over 40%, what happens to patients? Well, they don't generally do great. So over half of those patients where the temporary RVAD is removed, died. So 56% of patients died. And then the final option besides alive on ongoing support, but again, these are temporary RVADs. So this is a small cohort. We're not going to leave them in indefinitely, but they may be transitioned, and it doesn't happen frequently. But the third option would be, if you don't think you can explant it and maybe they're not transplantable, what happens if we convert them now to a durable RVAD? And here it's only 18 patients in this analysis of 1,000 patients, and 83% of patients die. So that tends to not go well. So when we need to convert someone with early acute right heart failure from a temporary device to a durable device, the North American experience suggests that these patients just don't do well doing that. And then the final survival curve that I'll share with you is the understanding that likewise, that patients may be different who get a durable RVAD compared to a temporary device, there may be inherent differences that guide clinician decision-making in someone who returns to the OR versus getting their RVAD up front. And so they did what's called a propensity score. So they they picked out patients that seem to be like each other. So they attempted to adjust for baseline characteristics and see if the risk of dying was any less if we took patients that looked the same, who got a concurrent versus a sequential RVAD, and doing that statistical modeling did not change the end result, and that hazard was still about a 50 to 60% increased likelihood of dying, independent of what their baseline characteristics were, including things like age, renal function, hepatic function, et cetera. So adjusting for other risk factors delayed by that implant or RVAD placement led to worse outcomes or increased risk of death over time. And I mentioned already that the timing of that operation wasn't something that was included. So we weren't able to look at RVAD placement within a day, a week, or 2 to 3 weeks from initial surgery. So looking beyond deaths, just two last slides here, really. So other outcomes beyond death are kind of analogous, that patients generally do worse. So this is within the first 3 months. Here's the p-value and event rate. So everything besides malfunction or pump thrombosis, which that patients who had a delayed or a subsequent RVAD had higher rates of bleeding, increased risk of infection, increased neurologic dysfunction, and increased renal dysfunction. And this was with the temporary RVAD cohort. The findings were analogous for the durable RVAD cohort, where they also had increased risks of those same adverse events. So they were not only more likely to die when they received a temporary or durable RVAD, but they had increased risk of bleeding, infection, stroke, and kidney failure. So with that, in conclusion, the incidence of RVAD use over time seems to be stable between 5 and 6%. The majority, just over 2/3, occur concurrent with the index surgery, so what we're calling BIVADs or simultaneous BIVADs. The majority of RVADs that are placed, about 90%, so 9 in 10 are temporary devices. Mortality in this population at large is much higher compared to those who receive an isolated LVAD. So 6-month survival was 63%, and on average, they were about 60% more likely to die than those who received an LVAD alone. And as I just mentioned, other adverse events or complications are also more common in this patient population. And with that, I will conclude and see if anyone has questions that I can answer.
Thank you, Dr. Kiernan. If anybody has any questions, you can put them in the Q&A box, and or if you have any questions about the presentation or about right heart failure or RVADs in general, you can go ahead and ask those questions. So far, no questions. Thank you, Dr. Kiernan.
All right, my pleasure. Thank you again.
Appreciate it. Do you have your contact information, or I could just forward you questions if they do come up later on in the webinar? Would that be okay?
Oh, sure. How do you want me to just...
Yeah, that's okay. I'll send you the questions.
Stop sharing here, but yep, you can...
I have a question.
I can put it in the chat.
We do have a couple questions here. Catherine is saying, I am new to Intermacs. This is great information. Can you explain hemolysis as a clinical event?
Sure. Yep, absolutely. So hemolysis is blood trauma, right? So it means shearing of the red blood cells. And, historically, when we saw, so hemolysis means there's turbulent blood flow through the device. So with the durable device, historically, we were worried about it predominantly with the HeartMate 2 or HVAD as a harbinger or marker of VAD thrombosis. So if we saw hemolysis, it generally meant there was a clot somewhere in the circuit of the pump that led to turbulent blood flow, shearing of red blood cells with elevation of LDH levels or bilirubin, indirect bilirubin. And we see other markers, hemoglobinuria, so hemoglobin in the blood. So that means bloody urine, but without red blood cells. It's just pigment. But hemolysis in someone with a temporary device could be different. It could be similar, but it also is not necessarily due to the etiology is not the same. So particularly with, for example, with an Impella device at high speeds, it's the same thing. You're seeing blood trauma shearing of the red blood cells, but not necessarily due to blood clot formation. Sometimes it can be because the Impella is entrapped in the mitral valve apparatus, and that leads to turbulent blood flow through the device. So the troubleshooting is different, I would say, in someone when we see hemolysis with the durable device alone, where we tend to historically think VAD thrombosis, versus when we see hemolysis in the setting of a temporary support device. But again, in this setting of Intermacs, that's usually temporary plus durable. And then we'd have to clinically figure out, is the hemolysis due to the durable device versus the temporary? But this day and age, it would almost certainly, or it would be much more likely to be due to the temporary support device. Hemolysis due to the shear forces in the Impella would be the most common reason.
Thanks, Dr. Kiernan. Just in follow-up, Catherine, who asked that question, she just had just a follow-up comment. The definition in Intermacs of the definition of the event is a plasma-free hemoglobin of greater than 3, or an LDH that's 2.5 times normal. This seems like most patients would have this event, would experience hemolysis.
I could just, from personal experience, plasma-free hemoglobin for us is a send-out lab with the delayed turnaround. So it is something we'll send, but not something LDH comes back real time that can guide decision-making. So, and I think the data, at least for durable LVAD use, has demonstrated that LDH is a more sensitive and specific marker of hemolysis than plasma-free hemoglobin. But in terms of the question about the absolute threshold, remember it's 2.5 times. So one thing about LDH is there are different assays. So it may not be apples to apples comparison across hospitals, depending on the assay used. But 2.5 times. We usually with the HeartMate 3 are not seeing that level. Again, it's an improved hemocompatibility. So I would argue that no, most patients should not have clinically significant LDH levels. They may, when they come in shock, if they're Intermacs profile 1, because LDH is not specific. If you have liver injury, you can have other reasons beyond hemolysis to see your LDH rise. That's where plasma-free hemoglobin can be really helpful. But in general, from the device alone, we shouldn't be seeing LDH. For my institution, I think normal is less than 200 or thereabouts, 220. So we shouldn't be seeing LDH levels on the 600 to 700 range with the HeartMate 3. That would be abnormal.
And then Cindy is asking, is tea-colored urine due to hemolysis?
It is due to hemolysis, yep. And again, what's important on that is when you look at, for us clinically, we'll get a urinalysis. And the urinalysis will have it'll have two different things. It'll say blood semi-quantitative, and it'll be 1, 2, or 3 plus or 0. So if you see 3 plus blood, but then you look down and they quantify the actual cells. So when they look at the urine under the microscope, so if you see 3 plus blood but 0 red blood cells, that means it's actually pigment. So there's a colorimetry. I'm not saying that correctly, but it picks up color, which it thinks it's blood, but in the absence of red blood cells. So that's how we would define hemolysis, or again, pigment in the urine that's turning it tea colored, but it's not actually blood in the urine. So there's no red blood cells present. And that causes a pigment nephropathy, an acute kidney injury or renal failure that can take weeks to sometimes recover from.
Tiandra has a question. ECMO was mentioned earlier in the presentation. Is there improvement of post-implant right heart failure events in patients that are on ECMO pre-implant?
Can you read that one more time?
ECMO was mentioned earlier in the presentation.
So yeah,
Is
someone who's
there,
on ECMO in advance of surgery. So then read the question following that.
is there improvement of post-implant right heart failure
Oh,
on pre-implant ECMO?
I haven't seen it. So what ECMO makes really challenging is assessment of right heart function because it's cardiopulmonary bypass. So I haven't, your question is, does ECMO improve rates of right heart failure after LVAD? I've not seen that analysis performed. It may be out there. What ECMO makes really complicated though is our ability to assess the right ventricle because you're bypassing the right ventricle. You're no longer loading it. So I can't answer your question specifically, but among patients who go on to, and I'm sure there are analyses of patients who get an LVAD from ECMO and what their outcomes are. I don't know that off the top of my head. I would be suspicious that ECMO necessarily improves risk of right heart failure, although what it does is it helps to resuscitate patients. And anytime we do that, if we get them hemodynamically optimized, hopefully the risk of right heart failure is a little bit low after surgery. But it really clouds our ability to do a hemodynamic assessment of how the right ventricle is doing once a patient's on ECMO. So there's sometimes we'll consider if we're really unsure, depending on the circumstances of why the patient landed on ECMO. It's different if they came in with a cardiac arrest versus progressive shock. If it's progressive shock, to me, that's probably a lot driven by the right ventricle, and I'm going to be uncomfortable potentially utilizing an LVAD alone. If they come in with a cardiac arrest, that's they're not really on ECMO to support the right ventricle. So different clinical scenarios. So sometimes we'll consider trying to wean the ECMO to a left-sided impella alone, which gives us an assessment now of how the RV interacts with the univentricular device. And if they do fine on a left-sided impella, then we're more comfortable converting to a durable LVAD. But it's a lot of different devices, it's different procedures, different institutions handle that differently. But ECMO is challenging when it's pre-LVAD.
Thank you. Tiana says, great topic and presentation. Thank you. Minnie says, that was wonderful. Thank you. Is there an estimated date that this recording will be posted? Is that the preferred way to share this presentation with individual institutions, VAD program leadership teams? So yes, Minnie, we will post this on the STS website with all of our other webinars. Carol, when do you think that this presentation will be, or today's webinar will be posted?
Sure. First, thank you, Dr. Kiernan, for a wonderful presentation. Always learning something new, and I know that our audience and really appreciate the clinical background for our databases. I think that this will be posted. I'll get this over to our marketing team probably by tomorrow afternoon, and it should be posted within a week on our Intermacs YouTube channel.
Thank you.
I have a question. This is Ryan. So this really highlights the value of the information that's collected in Intermacs surrounded right heart failure that's made possible by all the folks here putting in the data and taking care of these patients. So I don't know if this is a question for Dr. Kiernan or Patricia exactly, or just a comment, but thanks everyone for getting that information. It's definitely useful. And what kind of advice do you have for people that are struggling to enter these complex kind of situations?
Well, one, you took the words out of my mouth, Ryan. Thank you. I mean, again, the work of the people on this call is so incredibly important to guide the clinical decision making and management. Really, the majority of what we learn about caring for this complex patient population comes from Intermacs. So careful collection of these data is really essential for the work that we do. So thank you. In terms of your question, I'm not sure. I think often there's been an evolution for how right heart failure is defined in the registry. So to some extent, it's almost a question for Intermacs, frankly, leadership and less so guidance for I think the coordinators who are on this call, I think we per your question, we're seeking feedback. And we evolve over time. And for example, we weren't necessarily collecting different types of RVAD platforms in the past, be it a Centramag or Impella RP, et cetera. And those are all variables that I think moving forward, there's a plan to collect and to continue to increase the granularity of data. That does put some more burden. I know this is not easy. It's labor intensive for the people on this call to collect that, but it's the only way we can really advance what we're doing. I guess the one recommendation would be is if there's ever a question about whether or not someone meets adverse event criteria, it's to check with the PI at your institution or whoever the attending of record is on that service prior to recording it. So we know that the integrity of the data that's being entered is sound, because it's not always, particularly with right heart failure, and we've learned that doing these analysis, it's not always a black or white answer. So thank you for highlighting that. Hopefully it answers a little bit of what you're asking.
Minnie just had a follow-up question. She said, apologies if I missed this. Will you clarify for the early RVAD Intermacs model will be developed into a prediction model or a risk calculator for VAD programs to use in patient selection?
There have been, so the one I worked on is probably now a little bit outdated because that was data through 2015. So in terms of the data here, they did not, I did not see in this manuscript by Dr. Ahmed that they were planning on doing a risk calculator and risk model. Again, these models, from my perspective, clinically, models have just always underperformed. We want them to work because it help, we think it should help provide a yes or no answer, but there's such a big, the area of gray is so large that they're usually not nearly as helpful as we'd like them to be. So I think generally speaking, it's just kind of overall having a gestalt and knowing the clinical profiles of high risk patients and being prepared to shift gears. I think what's important, as I mentioned, is doing further analysis about what does delayed really mean? Are we okay if we wait a couple of hours, and if things are trending well, then we sit tight, but not continuing to flog for 2 or 3 days? And do we miss a window of opportunity? How essential is it truly concomitant in that surgery? I think is a really important question. But no, to my knowledge, those authors weren't planning on making like an online calculator. There are other risk calculators for the Momentum 2 in terms of survival, but nothing more recent for right heart failure.
Great, thank you. Colette says, thank you, great presentation. And that's all the questions we have. If anybody thinks of anything later on that they want me to pass on to Dr. Kiernan, I'm happy to relay your questions. Thank you, Dr. Kiernan, for taking the time.
Thanks everyone for being so engaged. Great questions. I appreciate it. Take care.
Yeah, thank you so much, Dr. Kiernan.
Okay, bye-bye.
Bye.
All right, Carol, I will share my screen. Moving on. All right, here's my contact information. I should have put this up earlier. If anybody has any questions or follow-up questions to Dr. Kiernan's presentation, feel free to reach out to me, patricia.potter@curso.net, and I will get your questions over to Dr. Kiernan. Brandon, would now be a good time to review those PDMAX dashboard updates?
Sure, I can run through those.
Stop sharing. Thank you.
So good afternoon, everyone. I'll share my screen here, but Patricia and Carol asked that I jump on here this afternoon. I know some of you may have seen these dashboards in various capacities before, whether it be the Intermacs dashboard or the PDMAX dashboard. But we added some additional exhibits to the PDMAX dashboard and just wanted to share that with everyone, as well as kind of reinforce the potential benefits of using the dashboard at your center in various capacities. So I will get into the dashboard here first. And for those of you that might be new to this, the PDMAX and both Intermacs dashboards were created to be utilized at centers to kind of provide a couple of different avenues of both checking your data as well as comparing your site's outcomes and other metrics against the aggregate of both other centers within PDMacs in this case, or PDMacs as a whole, or being able to filter certain kind of subpopulations within that. So the landing site here is just a general summary page that shows you counts of active patients, new patients, some other counts like implants and AEs, as well as some outcomes, transplants, deaths, cessation of support if that happens, things of that nature. And just as a caveat, this data that I'm showing today is a random sample of a few different sites data, just to find this hospital X. So we additionally show patient characteristics at your site compared to the aggregate of PDMacs. As you can see here at the top, there are these filters where you can select certain subpopulations based on age group, gender, race, device class, patient profile, and device strategy. Those same filter characteristics are then provided here in a form, in a figure that you can view.
Brandon, I think we're seeing your other screen.
Oh, I'm so sorry.
You're good. You're good.
We see the coding screen.
Yeah. Y'all are probably not necessarily as interested in my code as compared to the data. Okay, here we go.
Thank you.
Let me go back to the beginning here. Thanks for interrupting me and just letting me go on and on here. So again, here is the landing site of the dashboard that provides these counts. Just to have your site, kind of a brief summary of forms that you've submitted. Right now, this is currently updated on a nightly basis. So if you, for instance, put in a new bleed form or infection form, you can go in within the next day, check and see if those counts are then realized here at an rolling annual basis. So now here is the patient characteristics view where we have those filters at the top that you can select. Say if you were just interested in your destination therapy patients, you could select that, and that would show, okay, well, it looks like a random sample does not have any DT patients. This site. So if you're just looking at your bridge to transplant patients, you could compare those as well as any other subpopulations. Obviously, with numbers, the more filters you apply, the potential for not having any data to support your site or even PDMacs as a whole could potentially occur. But if you wanted to keep these filters applied as you look through the dashboard, you can certainly leave that there. And as you move through to the other exhibits, those would remain selected for you. I'll go back to all. So here's our adverse events tab. This is where we've expanded some of the exhibits here that you would notice. So we have added device malfunction and pump thrombosis, device-related infections, and pulmonary infections and GI bleeds. And so these new exhibits are in addition to those mortality, stroke, major infections, and device-related infections that we had previously provided to you in the same format, where you have a table showing you just your number of patients, count of events that occurred, and then a patient percent and a rate. I will go to, let's see, pulmonary infection. Yes, so pulmonary infection has some for this random sample. As you can see, it provides you, again, this table, as well as a figure kind of showing that trend line over the last 4 years. And then again, GI bleed as the other exhibit we added. As you can see, there are very few events that occur within 30 days of some of these. You can compare within your site to kind of to be able to see, okay, it's also a very rare event that's occurring across PDMacs as a whole. One of the other things we did was we changed the calculation of our patient percent values. Those were previously kind of really displaying more of an event percent per year. We have now fixed that to where it shows a true patient percent value. So if a patient has more than one event, they will still only be counted once in that patient percent calculation. So just as a continue on, this is still the same that we have provided previously. Nothing new added here. We provide you this metric benchmarking tab, which looks at your length of stay, both at a patient level as well as a hospital level. Again, being able to compare to PDMAX aggregate, as well as being able to apply any filters that you might want to apply to look at a subpopulation within your hospital. Again, if you want to look at how you compare against other hospitals instead of just that aggregate PDMAX or all aggregate PDMAX patients, this is looking at all hospitals within PDMAX. So it provides you the median length of stay and see where your site falls kind of on the range of other sites that are submitting their data to PDMAX as well. And Patricia, that's all I had, just to quickly run through those new exhibits in that fix. Again, apologize for you all having to look at my statistics coding for a few minutes, but
Thank you. Does anybody have any questions for Brandon before he hops off? We do, if you do, you can put it in the Q&A box. There is one comment here. Melissa had said these dashboards are most useful when more than one person at a center can access them and manipulate the inputs. You're right, Melissa. Right now, we do have it limited to one person at each center. We assigned it to the person who historically had used the dashboard the most. Most cases, it was the site admin, but in other cases, there were other users that had used it more, so we assigned it to that person. If you want to change who's designated at your center to have dashboard access, you can send me an email and I can walk you through that process. But right now we do have it just for one person at each center. And then Tiandra had a comment, Brendan, real quick. On the main landing page, it would be extremely helpful if the dates would include data from the most recent STS Intermacs quarterly reporting period. Example, next 2023 Q2 coverage period, January 2022 to June 2023. So
I'm trying to decipher that. So does that mean it would be helpful to have this broken out into more granular timelines instead of by year, to have it at a quarterly level?
I think, yes, at a quarterly level and
Well,
based on the most
the
recent.
Intermacs database is dashboard is a little bit different. The PDMax is broken into quarter because there's the year annual because there's so few events, but the Intermax version of this is by quarter. I'm just wondering, I think there's a rolling 6 quarters in the QA report. So maybe that's the distinction. Let's see if the person that asked the question could comment on that. The other thing is we're actually updating this at a quicker cadence than the QA reports. So it actually QA reports only update quarterly, and this is adding in those kind of mid-month months as it becomes available. So that was my only comment.
Yes, but Ryan, that's right. She said yes. She said yes, it's a rolling 6 quarters. All right. Any other questions for Ryan or Brandon?
I will say that in regards to what times are being displayed on any of these exhibits, really, we do have it kind of in our goals and in our future plans to update both PDMacs and Intermacs dashboards in order to provide a little bit more user customizability down the line. And that includes being able to have the user have the option of selecting what timelines you're visiting. That's kind of in the near, within a year or so, hopefully, or in the next year or so, hopefully being able to provide more user customizability of that. The timing of what you're seeing, whether it's rolled up by yearly, every 6 months or quarterly basis, and then also kind of being able to look beyond just say the past 4 years or past 4 quarters, to kind of maybe hopefully get at what you're mentioning is looking at a rolling 6 quarters.
All right, thank you, Brandon, so much. Appreciate that. It doesn't look like we have any more questions related to the dashboard. Catherine, I do see your question here, and I will send you an email, but I do want to just answer it live just in case anybody else on the call has the same question. She had asked, Patricia, can you explain how to document in Intermacs if the patient has an RVAD placed post-durable LVAD insertion? So I do just want to comment on that. So this would be the scenario of the patient had their durable device entered, and then after they leave the OR, they have to go back and have an RVAD placed. So you already have entered you would enter your durable LVAD as your device type, go through the entire implant process in Intermacs, and then up at the top on the patient summary screen, there's an option that says add new device. When you click on there, you'll only have the option to add an RVAD because you already have an LVAD in place, so the database wouldn't allow you to add a second LVAD. So we'll only give you the option for an RVAD. When you click on RVAD, that will prompt you to complete the pre-implant form and the implant form for the RVAD. And then on the implant form under device type, it will already be selected for RVAD. So it's added to the existing patient summary, and you're just going through the implant process for the RVAD. So that would be adding a RVAD separate from the LVAD. So I will email you in case you have any follow-up questions on that. I took note of your email, but if anybody else has any questions on that, feel free to reach out to me. And then Rona had the question on Intermacs AE reporting. Does all LVAD thrombus seen on imaging always classified as device malfunction, whether it is occlusive or a non-occlusive thrombus? Yes. So if the patient has any type of pump thrombus, it does need to be entered on the device malfunction pump thrombus AE form. So those are our questions. Carol, we're over time. Do you want me to continue on, or what would you like me to do?
Yeah, if you just have, I'm happy to stay on for maybe 15 minutes longer if that's enough time. We could figure it out, Patricia. If you want to go ahead. This is recorded, so if anybody has to jump off, you'll be able to listen to this in about a week for the additional information.
Thanks. Okay, so I did want to just go ahead, Carol.
I was just going to say, is that okay with you, Patricia?
Oh, yeah, that's good with me.
Okay.
Just move through my slides real quick here. So I did want to just talk real quickly about AQO because it's coming up here quickly. AQO is the Advances in Quality and Outcomes meeting, a data managers meeting. I've put together some steps to find the link to register for the event. Let me just advance my slides here. So if you go to the STS website, this is in the education tab. You can click into if you click into the calendar of events, you'll see it posted. As you can see, it's a virtual event this year. Last year we were in person, and I believe next year we're going to be in person again. So this year is virtual. It is September 26th to the 29th. Intermacs and PDMacs will be on the 26th. And registration is open. Of course, we encourage you to register. This is a great education opportunity, and it is full of really good information. And we have Q&A after each talk, so you can ask your questions. Next year, if we are in person, it's a great networking opportunity. It's nice to be able to put faces with names. Last year, after the conference, we did a hot topics review afterwards, which was really nice. Sometimes at AQO, we get quite hard questions or questions we can't answer. We need to take them back and discuss them. And having the hot topics webinar gives us a chance to answer some of the questions we couldn't answer and get those back to you. It went well last year. It was well received, and I believe we're going to do that again this year in December. So AQO registration is open. Here is the registration pricing. If you're an abstractor only for Intermacs or PDMacs, you probably only want to sign up for the 1 day, but if you abstract for multiple databases, you can see there's a option for multiple days. So that is AQO. We've got a really great agenda planned for that. Our next Intermacs user group webinar is going to be October 25th. We're not going to have one in September because it would normally fall during the week of AQO. And then, I just wanted to show you how to find where our Intermacs webinars are. It looks a little bit different, but it's under the data manager resources. Here is user group call, shows you how to join it, the date and time. And then also it shows our most recent webinar with the slides and the recordings. We typically have one user group webinar a month. I know we've kind of missed a few over the summer, but we're getting back on schedule here. And then we do a quarterly reports webinar as well. We do those quarterly. Okay, and then I mentioned earlier that we're going to be making some changes as to how we handle RVADs when they are connected to an oxygenator. So the decision that has been made is once an RVAD is functioning as an RVAD without an oxygenator, the device should be entered into the database as an RVAD. If at any time after that, the device becomes attached to an oxygenator and is now functioning as ECMO, we're no longer going to ask you to explant the device, which is really nice. You can just leave the device as is active in the database. And then once the device is explanted, you can enter the explant form at that time. And then in order to capture the number of days the patient's device was functioning as ECMO, we've added some questions to the pre-implant form, the implant form, the explant form, the death form, and the implant discharge form. So it's just like one question a form. And I'm just going to go through those really briefly and show you the questions that are going to be added. And this is not live yet. It will probably be coming in the next couple weeks. So I just wanted to give everybody a heads up and go through this in case anybody has any questions. So on the implant form, there is now a child question. So the question was already existing. ECMO, was it present at the time of durable MCS device placement? If you say yes, there's now a child question asking for the total number of days on ECMO. And then on the implant form, once you select that there was ECMO insertion during the implant surgery, a child question will populate to capture the total number of days. So if you select yes here to ECMO insertion, a child question will populate total number of days the patient was on ECMO. And then on the explant form, the question was the patient on ECMO at any time since implant of their durable LVAD. If you select yes, it asks for the number of days. So that was the explant form. And this is also on the explant form. So this will be when you're explanting the RVAD. So the RVAD that it was one time functioning as ECMO, and now you're explanting it, this is the form you'll be doing that on. And then the death form, same question. So all of these additional questions are in lieu of explanting your RVAD just because it's attached to an oxygenator. So in order to be entered into the database, it needs to be functioning as an RVAD. So you need to wait until an oxygenator is removed. But once it is functioning as an RVAD, you can enter it one time in, leave it for the duration, and then explant it with the explant form once the RVAD is taken out and turned off. So those are the additional questions, and those will be coming probably in the next few weeks. Oh, and also on the implant discharge form, same question. All right. Does anybody have any questions?
Good job, Patricia.
Thanks. All right, Mary. For Intermacs follow-up, we do not usually do the hemodynamics. Is there a way to put not done that all the child fields could disappear instead of putting not done in all fields? Mary, that's a great question. So we've talked about this before. And basically the consensus from the leadership was that they didn't want to do that because they're worried, we worry that, potentially something could be missed if we just put not done to the whole form. There could be something in there that you could complete. So we have talked about it before, but at this time, we're not going to make that change.
Yeah,
then,
we do something similar in the other STS databases. We don't like to default to an answer for a whole bunch of questions. So we usually try to avoid that with the defaulting answers to no with a parent field. Does that make sense? Yeah, I think we're
yes, it does.
consistent across our databases with that.
Yeah, yeah. It's just, worries that something could be missed.
Yeah, right.
Hey, Marie, if we are unavailable to attend AQO that day, can we register and access the presentations later? Carol, will they
Sure.
have, so because it's live virtual, if they register, they'll see all the live and the on-demand content, right?
That's right, yeah. And so the on-demand content is usually available a week before AQO. We usually try to have that up a week before so you can watch that content ahead of time. And then we have AQO the week of the end of the last week of September. And then that content is also will be made available on the platform as recordings. So you'll be able to see that as well after AQO. So, and then we usually leave the platform up. I think it's about a year that we try to do that. So we leave that information up so you can go back and review it.
And they'll also be able to join the Hot Topics webinar, right?
Yeah, that's going to be an invitation only to those who register for AQO to get invited to the Hot Topics webinar for all of the databases. We plan that. I think we'll have one day dedicated to each database. So we have the four databases combining PDMacs and Intermacs together. We have one day. It's usually about a 4-hour. Oh my gosh, I'm so sorry. It's usually about a 4-hour webinar. This is the post-lunch yawn. I apologize for that. I haven't drank enough caffeine today. It's usually a 4-hour webinar we dedicate to questions, like Patricia had said earlier, dedicated to questions that come in during AQO that we maybe weren't able to get to or we need to revisit internally and didn't feel comfortable answering the questions on the spot during AQO. And then also sometimes other things come up during AQO that we need to, we realize that maybe we need to provide more in-depth education on. So we also will take the Hot Topics webinar to go over that type of thing. And then if needed, we'll bring those topics out to regular webinars. But yeah, the Hot Topics webinar is just a invitation only to those who register for AQO. That helpful? Sorry, I went on in like a
No,
circle.
that's super helpful. Thank you. And I feel bad we haven't really gotten to talk a whole lot about AQO with the Intermacs community. So if anybody has any questions, feel free to reach out to me. We have a really good agenda for AQO, so I hope many of you can attend.
I wonder, let me see if it's posted yet, if we have a preliminary agenda posted yet for AQO. I know we need to get going here, but if anybody's on the fence about joining, I think it's I really like this agenda. I think it's going to be very informative, and I actually looking forward to it. It's going to be very good. Hold on one second if I can find it. I have a hard time sometimes on our website finding things. Let's see. Oh yeah, we do. Let me pull up the agenda here.
I'll stop sharing for you, Karen.
Okay. I think I do. Hold on. Oh yeah. I'll share my screen here. Okay. Oops. So Intermacs will be on Tuesday, September 26th from 11 a.m. to 6:10 p.m. Eastern time. We have to use this time because we try to consider all of our time zones. So 11, 10, 9, 8. This is 8 o'clock Pacific time. So we don't want to start too early for the Pacific side. And so topics, Patricia, did you want to go through these? Because I know you've been really part of the planning on this.
Yeah, sure. I'm happy to go through them. So we'll start with just welcoming from Catherine and I, and then Dr. Kirkland is going to talk about what's new in the research for Intermacs and PDMacs. Dr. Shaw will be the next presentation, and he's going to talk about readmissions and the rehospitalization form. And then at noon, Dr. Grinstein's going to kind of tie together hemocompatibility, neurodysfunction, pump thrombosis, and device malfunction. So that's like a good chunk of our AEs and kind of how they they kind of all are correlated and go through all of that. And then Dr. Grady is going to talk about quality of life post-implant and the importance of the quality of life forms and collecting the quality of life data at your center. We'll, of course, have a break, and then we'll have an award presented by Catherine. And then Dr. Cowger is going to give a presentation, how to use Intermacs data, quality initiatives, and performance improvement. And that presentation is going to kind of all be combined between two different coordinators, Rebecca and Sheena, Sheena and Rebecca are going to kind of discuss how they use the data at their center. So you'll get the perspective of two different coordinators. And then Dr. Brandon Singletary, who gave us the PDMacs dashboard updates today, he's going to give us a talk on utilizing the dashboard to drive quality at your center. And then we're going to just go through some documentations of our different AEs, chronic driveline infections. Sylvia is going to talk about right heart failure and kind of touch on the updates that I just gave on changing our practice moving forward on handling devices once they begin functioning as ECMO. And then we're going to have some nice PDMacs content from Carrie. She did a great presentation last year. She's going to do another PDMacs presentation, and she's going to show us how to, she's going to walk through a dummy patient from hospital X, putting in a patient. So it'll be some live demonstration there. And then Dr. Pagani is going to talk about Intermacs patient profile, and that's going to be our Intermacs PDMacs agenda. So that will be our live virtual presentation. And then there will be these talks on demand, and you can listen to these at your leisure. Carol said these will be typically available about a week before AQO. Maceo Cleget is going to talk about data completeness. John Pennington on quarterly data set usage. I've seen part of his presentation. He has some really great tools to show in his presentation. So definitely check that one out. Devin Cole, she does a fantastic presentation on live data downloads, and she's going to give us that presentation this year. Brandon's going to talk more about the dashboard. And then Sheila Bailey is going to talk about auditing. She's had some experience with Intermacs and PDMacs audit and kind of how to prepare and going through the audit process at your own site and what that will look like. So we have a really full agenda with some really great presentations from some really fantastic speakers.
Thank you, Patricia. I agree. I think it's a fantastic agenda. There's so much there. It's so heavy, information heavy. It's going to be hard to sit through a whole day, but that's why these are going to be recorded and available to those who do join us purchasing AQO. You'll be able to have access to these. I think it'll be for about a year. We'll make these available. I mean, it's so dense. There's so much info here.
Yes.
I sound like I should be working on an infomercial, but I don't mean that like it.
So that's AQO. If anybody has any questions, and like Carol said, if you're on the fence and you have anything specific you want to ask, feel free to send me an email. I hope to see lots of you there. I know we're virtual, but it'll be nice. And then our next user, like I said, we won't have a user group call in September because it's the week of AQO. We will have a call in October, and then Carol, we'll do Ryan's still on the call. We usually do a quarterly reports webinar, so maybe that will be in like November or December.
I think I have that on. I see that on the calendar for Thursday, October 19th.
Oh, okay. So we'll have two in October. So we'll do
Yeah.
a user group on the 25th and then a reports webinar. And so that's a great opportunity. If you have any questions about different exhibits on the report or reading your report or anything like that, that's a opportunity for you to ask those questions. So that will be October 19th.
Yep, that's what I have. Okay.
Sorry we kept everybody late. It's been a while since we met, so there was just lots of information to get out there.
Yeah, thank you so much, Patricia. Great job on leading the call. And thanks to everybody for joining.
Thank you, everybody. Have a nice afternoon, and we'll meet again, hopefully at AQO.
Take care. Bye.